Hi, good morning, guys and girls. So, I have this topic that I want to come to talk to you guys about pretty briefly because I don't have much time on microwave diagnoses. And by the way, the air quality is like crap out here. That's the reason why my eyes are like watery, and everybody is being affected by these fires that are around LA that are just popping up. And I think they're mainly in the valley, and they kind of just popping up different places, and people had to evacuate. And so even I was talking with my colleague yesterday how like the fires are like impacting our eyes and making our eyes pretty watery and dry. Like they're drying our eyes out, but the natural response when your eyes are dry is that, they produce water. And so just like, I find myself having to do this a lot. But anyways, we'll get through this. So yes, microwave diagnoses, because in this field of psychology that I'm in, it's interesting the process how many clinicians go about treating patients, as they call them, or clients, treating their mental illnesses. And typically, like in the medical profession, doctors, they have assessment tools that they use. They give patients tests, usually blood tests, to determine what's going on with them, right? Or they do x-rays, just a number of different kinds of tests that they implement to assess what is the client's problem before they go in and try to treat it. And that reminds me of Dr. Daniel Amen, who is a leading psychiatrist in the field. I think he's based out here in California. He has offices set up all around the country. He's well known. But he has this saying that he says that psychiatry is the only profession that attempts to treat the problem or the patient who has the problem without looking at what's wrong with them, without actually doing an assessment to see what's wrong with them. It's like you just go in and prescribe medication. It's like we are the only profession that don't look at the organ that we treat, the organ being the brain, because that's what the psychiatric medication is for. Now, a lot of people I know have some confusion surrounding the difference between a psychiatrist and a psychologist. Some people think they're the same, but they're not. Psychiatrists do have much more training experience than psychologists. So psychiatrists, they are trained in medicine and psychology, whereas psychologists typically are trained in psychology. I mean, we have exposure to medicine and the bio basis of human behavior, but primarily we're trained in studying human behavior, which is psychology. And so with him being a psychiatrist and him treating the brain, so to speak, he has this thing. That's what I think sets him apart from every other psychiatrist, being that he makes an effort to actually look at the brain, whereas other psychiatrists just go in and be like, all right, you say you feel this, you say you have this, you're endorsing this symptom, all right, here's a pill for it. But no, he's invested in many millions of dollars in technology to do brain scans. That's like his meat and butter of his practice. He's done lots and lots of brain scans where he looks at the brains of his patients to determine what's happening, what's going on there. And from that, he said he's learned a lot. I am on a busy street, so sorry you guys. Hey, this is what I got. But yeah, sometimes finding locations to do these videos can be the biggest challenge to doing the video, actually, in and of itself. But yeah, he's like that he has even done brain scans on people who were on trial for criminal offenses, just to determine that it wasn't necessarily their choice or their behavior that led them to do that. I mean, behavior obviously is a part of it, but it was primarily, a deficit in their brain that triggered them to act the way they did in a certain situation that led to them committing a crime. So I'm like, I find that quite interesting that a brain scan can get a person off, of a criminal case. But it's amazing, and I think that's very necessary. And thinking about the way psychologists treat clients and a lot of clinicians, just different agencies, they don't do assessments, they don't do testing. And that kind of bothers me, because even the place where I work at now, out here in Inglewood, they don't do testing. my concern is, my question is, how can you go in and treat a person without thoroughly assessing them for different issues, clinical issues, you know? You just go in and be like, all right, they present with this, I observed this, they endorse this, so I'm just gonna go in and fix the problem. And I'm just like, nah, man, that approach really does not sit well with me, and that's the reason why I am doing this video. And I do have to be mindful of the time. 10:33. I'm doing great. So yeah, I think I'm gonna go for another 27 minutes. But yeah, it's like, and there's so many different tests out there. Granted, we are all as psychologists trained in testing and assessment, but many psychologists, even in private practice, they don't rely on testing to treat their clients. They may give them an assessment, like a survey or an inventory, but that's not the same as testing. Testing is more thorough. It's a thorough approach, and it uses certain instruments that are validated empirically, you know, that have kind of went through the ringer to make sure, okay, that they're measuring what they say they're measuring, which would speak to validity, and that they're reliable tests, you know. And one of those tests is the MMPI, stands for the Minnesota Multiphasic Personality Inventory. It was developed in 1939 and published in 1943 in the University of Minnesota Press. And it's an awesome assessment. I think it consists of 567 questions, if I'm not mistaken. A lot of questions, like hundreds. It's a lot of questions that clients have to answer, but the benefit is that it's able to tap into a wide array of clinical problems that a client may be experiencing. And having that as a tool that a clinician can use is priceless, because not only, like, clinicians just have to go in and be like, okay, I think it's this, so I think they have this. No, you actually have an empirically validated measurement, a tool that can support your hypothesis, I think, which is really important. Now, of course, there's some drawbacks to the MMPI because, okay, I'm going to go over the scales. So there are 9 scales, 567 questions. I'll fact check that for you guys just to make sure, but I'm pretty sure that it's 567 questions that are on the MMPI. It takes several hours to complete. I think it takes it depends on how fast a person moves, you know, because the thing is, the questions or the prompts aren't that long. You know, the sentences that the clients have to read aren't that long, because it's true or false questions. So they read the prompt and they just endorse true or false. But the results yield, they have 9 scales. 8 of the 9 are actually clinical scales, and the first scale is hypochondriasis. The second is depression. The third is hysteria. The fourth is psychopathic deviant. The fifth is masculinity, femininity. 6 is paranoia. 7th is psychasthenia. 8 is schizophrenia, and 9 is hypomania. And so, of the 9 scales, the one that's not necessarily a clinical scale is the 5th one, masculinity, femininity. And it's not clinical because it says that basically it doesn't provide clinical information, like clinically significant information, which, I don't know, that can be up for debate, because where one falls on the spectrum of masculinity, femininity can help inform certain clinical decisions that are made in terms of treatment, but in terms of diagnosis, it really doesn't speak to diagnosis. So, but the other 8 scales do. And I think the MMPI is a great tool to use, like I said, because it gives us so much information, and it's used for a variety of reasons in different settings. It's used in therapy. Psychologists use it, therapists use it to differentiate between diagnoses, to see, okay, is it depression? Is it hypomania? Is it psychasthenia? And psychasthenia is a very interesting term. I know some of these terms, y'all like, what does that mean? But no, psychasthenia basically, when it was first created, refers to OCD. But interesting enough, when I was trained in my assessment course, my professor said that it relates to anxiety, which OCD was classified as an anxiety disorder, I think in the DSM-4 TR. But now I think OCD actually is a disorder that stands kind of in its own category. So interesting how things kind of shift in our field. But yeah, to be able to differentiate between different diagnoses, that's really important, because you don't want to diagnose a client, let's say, with schizophrenia, when in fact it could be something else. And another thing is that it's important for clinicians to know when they find that clients are elevated on certain scales. And a clinical elevation is basically meaning that the client, when they scored the responses from the inventory, that they found that the client the sum of their scores is clinically significant. And in order for the scores to be clinically significant, I think it has to fall within the 65 range. So they have to get a score of 65 or above on the clinical scales for it to be clinically significant, meaning that it's of clinical attention, something to focus on, something that the clinician is going to hone in on to say, okay, this is important. And a client actually may score 65 or above, let's say schizophrenia, but that doesn't necessarily mean that the client has schizophrenia. So it's important to take into consideration the entire clinical picture. So not just to say, take the scales or the results from the scales and say that they're conclusive. No, they're not necessarily conclusive or definitive. That you have to really consider the entire clinical picture. You look at observations, you actually even cross-validate. So you use other scales to support whatever you found on one inventory. If you found that the client was elevated, let's say on schizophrenia on the MMPI, then you may want to give them another measurement to validate that. And even with that, I was going to say that some clients, particularly clients who are religious, or they've found that even African American clients actually commonly rank high on schizophrenia, because it taps into certain questions like being able to hear things or see things that aren't there. And if one is not careful, you can misdiagnose a client based on, let's say, if they're a religious person, they say, well, I hear God's voice. It doesn't necessarily ask, do you hear God's voice? It just says, do you hear or see things that aren't there? So that's something to note. This table is kind of wobbly. And even certain factors like familial stress. There's a lot of stress in the family that can also lead to an elevation on certain scales relating to anxiety. So that's just important to consider, because yes, the family context is important, but you don't necessarily diagnose a client based on their familial context. I mean, it's a family that has the anxiety or the environment that is anxious, not necessarily the client, but it's causing the client to become anxious. So that's something to really consider. And I think that, unfortunately, a lot of these agencies, they don't do differential diagnoses. They just go in there and they go off the hunch. And honestly speaking, like, I've kind of observed that even where I work. I mean, it's weird, because you'll sit in supervision and you'll have psychologists who, I'm just spitting. Hey, Kwame. But you'll have psychologists who will sit at a round table and they will deliberate on clients and what could be their diagnoses, right? What it is. And they'll be like, oh, well, maybe it's this, or maybe it's that, or maybe the client is experiencing. I was like, that's just too much freaking leeway. That's too much room for error. And I don't really like that. Like, granted, I think that, and that's the reason why I chose the PhD program as opposed to the Psych program, because I am more on the scientific side. Like I'm a person that is very logical and likes to deal with numbers and facts. Like I kind of think that way. You know, although I'm an artist, yes, but I think the way my mind works, like you have to give it to me straightforward, and it has to be backed up with data. You know, like I appreciate that aspect of our field, where a lot of psychologists, they're like, I don't really care about the science part, you know, or the data part. Like they don't really pay attention to that. They just kind of go off hunches, right? Or the best educated guess. And I'm like, nah, man. Like it makes no sense. I mean, yes, we want to think critically, right? So we want to brainstorm on what the possibility could be for our clients, but you don't want to be in there and be like, oh, well, maybe she's overweight, or maybe she overindulges in food because of this, or maybe it's that, and then you just draw a conclusion based on how everybody feels. So if most people say, oh, okay, maybe it's this, and you're like, okay, yep, that's it. It's like, what kind of science is that, you know? And it's like, no wonder our field is not really respected, because people, they rely too much on the hunch. Meaning like, okay, whatever your gut tells, if your gut tells you is this and is that, and yes, you want to kind of rely on that too. It's not to totally dismiss your gut instinct, but come on, man. I feel like we talking about people's lives here are at stake, and then you want to just sit up here and come up with guesses without even data to support that. Like, I don't like that. So I'm definitely, for my next practicum site, I am going to make sure that I get experience in testing. And ironically, my first practicum offer that I received, I actually was placed at a testing site. And I told you guys about this, where I actually was placed at a site where I was going to be doing assessments and testing on preschool children, mostly African American preschool children. But at the last minute, the supervisor, the training director, she withdrew her position from the agency. And she was like, I'm no longer going to be supervising interns here. And I'm like, what in the hell? This was like the perfect experience, because for APA, to get an APA internship, most APA internships require that PhD students have testing experience. Testing is important. You know, not only do psychologists do therapy, we also do testing. And a lot of times, like, people just forget that, and they just totally dismiss the testing aspect, which I don't like, because I'm like, wait a minute, something is missing. And even in working with my clients that I have now, I kind of get that feel like, damn, something is missing. You know, I will be able to make a better informed decision on what to do with this client in terms of developing a treatment plan if I actually was able to give the client some tests. But no, the main inventories that we use are the Beck Depression Inventory and the Anxiety Inventory, which are helpful, yeah. But I mean, there's more diagnoses in depression and anxiety that exist that a client could be experiencing. So I'm just like, come on. There's other stuff out there, you know. And the MMPI definitely, I think, will help to be able to differentiate between what's going on with the client, because there's so much that it assesses. They have so many scales. Those are the main clinical scales, but they also have sub-scales too that are very helpful in determining what's going on with the client. When you give a client the MMPI, it's really helpful, and it's valid. You know, it's been used on many different populations, you know. Yes, there are cultural considerations to take into to consider, right? But at the same time, I mean, that's with anything, you know. You definitely have to consider culture as a factor before, you know, when you're diagnosing a client. But yeah, I just think that that's really important, and it's just, it goes over some people's head. And I think a reason why a lot of these sites don't do testing, because they don't have the time. They don't want to go through the extra work, because testing requires work. It requires attention and time, which psychologists just bypass. They're like, okay, we're going to skip that part. We'll do an observation of the client's presentation, but it's only so much you can observe from a physical presentation. I mean, some people are very good at hiding certain things, honestly. I mean, you can come in there well-dressed and well-groomed and know how to put on an act, so that you're not perceived as crazy, because that's the biggest thing that a lot of people, when they go to see a psychologist, especially certain populations, ethnic populations, they're like, I don't want them to label me as crazy, you know, I don't want to be considered as crazy. So they go in there and put on a good show. And for the client who's able to put on a good show, guess what? You're not going to know what's lying beneath that, what's going on beneath that. But they have tests that are able to pick up on that. And like I said, the MMPI is one of them. And also what I forgot to mention is that the MMPI actually has lie scales, four lie scales within the MMPI, that is able to determine if a person is faking good or faking bad. You know, if they're actually over-endorsing certain symptoms or under-endorsing, under-reporting. They call it over-reporting or under-reporting, but it's able to pick up on that. And if they come to find out that they're elevated on certain life scales, and that's important for the clinician to know, because if they are, then that actually would make the rest of the inventory invalid. That would invalidate the rest of the responses on that inventory, because they actually scored high on these lie scales. So it's kind of built in, like a lie detector test. It's kind of built in the MMPI, which is great. And I actually believe that honestly, if every inventory or assessment could have, or test could have these lie detectors built in, that would be phenomenal. Okay, I only got 10 more minutes.
You beat the orange juice?
No, this is a mango tango.
Oh, mango tango. Oh, the mango tango. Yeah, it's good.
It's good. Yeah, I got ginger with it too.
That's good. You paid $10, huh?
This is a large one.
Oh, okay.
Yeah. So yeah, this is pretty good, y'all, what I'm drinking. But other tests like the WAIS, it's an intelligence test. The MMPI, I mean, they call it a personality inventory, but it assesses psychopathology too. Oh yeah, I was gonna say before I talk about the WAIS for a minute. The MMPI is used like across different settings. It's used by therapists. It's used in forensics. You know, I already kind of mentioned that too. And it's used even by employers to assess potential employees' personality, like to see. I mean, because that's important. Like, you don't want to hire a person who, you know, who scores high on, let's say, psychopathic deviant or schizophrenia. You know, given that it does not due to religious reasons, you know, or spiritual reasons. But yeah, that's something to note. That's something to take into consideration, you know, because it's just the way that a person thinks that could interfere with their job performance. But yeah, the WAIS is also a very helpful assessment that psychologists use. And the thing is that it's important to note that psychologists are able to do testing. Master's level therapists are not. They don't have the ability to do testing. It's not within their scope of competency to do it, because they're not trained to do it, whereas psychologists are. So MFTs, marriage and family therapists, or licensed professional counselors or mental health counselors, they are not able to do testing because they're not trained, but psychologists are. So that's one great thing. And granted that we are trained to do it, it's like, why not do it? You're trained to do it, just do it. But a lot of people are like, no, because they don't want to go through the administration, because it requires a lot of focus and attention on the behalf of the psychologist to be able to administer some of these tests. Like, some of these tests you can't just give to the client and be like, all right, do this, and it's up to the client. No, the therapist has to be very much attuned and very much alert and aware in doing the administration. Let's say, for example, when administering the WAIS, the Wechsler Adult Intelligence Scale, or the WIS, the Wechsler Intelligence Scale for Children. It's important that the psychologist is like on their shit, you know, because it's going to screw up the whole administration, the whole validity of the test if they're not. But the WAIS and the WISC are helpful because it's able to assess working memory, processing speed. It's able to assess verbal comprehension, perceptual reasoning. Those are kind of like the main scales on the WAIS and the WIS. And those things are really important to know for psychologists and working with clients. I mean, because if a client has issues with processing, right, or their working memory, or their perceptual reasoning, like that can impact the course of treatment. That can inform the course of treatment and help determine how a therapist should go about with the treatment plan. You know, or even before they develop the treatment plan, obviously the most important thing is the diagnosis, the conceptualization of the client's problem. And too many therapists, they skip over that. They dismiss it. And it's like there's a great example. A therapist may see a client, right? And the client may appear to be resistant, or appear to kind of be dismissive, right? Or not receptive to what the therapist is saying. It's like, oh, they're just resistant. And so from that observation, physical observation of that the therapist has taken in by the client, from the client, the therapist may conclude that the client is oppositional. But if that same therapist, or aka psychologist, was to give that client an assessment that taps into processing, such as the ways, you know, then they will be able to know that, okay, this is a more specific issue that the client is having with regard to the way they process information. Not everybody processes things the same. And I have a colleague, she's wonderful. Her focus, her PhD dissertation actually is going to be on processing disorder. It's a real thing out here, you know. It's a way that people process information, and people just process it differently. And her focus, she says, is on African American women, because it's a misconception that African American women are stuck up and they're resistant or this and that. But it could just simply be the way that they process information is just different. I would say they do it slower. It's just different. The way they encode it, the way they retrieve it, it's going to impact many different interactions. But if you just jump to the conclusion and say, oh, well, that kid or that adult is oppositional because they're not receptive to my feedback as a therapist, then you totally missing the client, man. When it could be a neurological thing that's going on in that person's brain. Hello, but they totally missed that. But I do have to go. I just wanted to kind of put that out there for the general public. And I guess mainly for therapists or psychologists who come across this video. I think it's not often that psychologists or therapists will find my videos, but just in case, it's out there. It's out there for the public to know, because it's so important, especially for clients in choosing a psychologist or choosing an agency to get therapy services from. It's like, you want to make sure that they are taking a comprehensive approach to going about things. The air is so dry out here, y'all, in California. And you want to make sure they're very thorough. I'm a kind of person, I'm so detail oriented, very conscientious, and very thorough. I don't care how much time it takes. I'm okay with the time. I don't care about that. If it takes 12 hours to determine, 12 hours of testing specifically to determine what's going on with the client, then let's do that. Because we need to make sure that we're not missing the mark and we're just jumping to conclusions because, oh, we think we know. Oftentimes we don't. And I think I feel so passionate about this because I think I've been missed as a person, as a student. Like, people totally missing me, and they think, oh, well, she's not receptive to this, she's not this, she's like, come on. Y'all don't know me as a person. And people are very quick to make judgment and assume that a person, okay, they look at it through a behavioral lens. They're like, okay, so if you're not compliant, then you're doing it on purpose. You know, you're being this way on purpose, and totally miss the person. It happens in school settings too. Teachers, they're like, oh, that kid just keep getting up out their chair. That kid, you know, don't want to listen. And it's just like, it ain't got nothing to do with the child's desire to want to learn. I think everybody is wired to want to learn. It's something else that's going on. It's the environment that may be causing that child to not feel comfortable to sit in that chair for 8 hours a day and just listen to what the child is saying and the teacher is saying. Because people have different learning styles, which, I mean, we learn this in school, right? It's like beat in our head, the different ways that people learn, the different types of intelligence, according to Gardner, that people have. But they don't put it into practice, man. They preach it, but I swear, and when it comes to practicing it, they don't do that, man. They quit. And that's the reason why I titled this video Microwave Diagnoses, because They just want to be quick with it, and to get patients in and out. It's just like a freaking what they call it, the what's the name line, you know, like a production line. You just want to put clients in the production line, just keep them going, keep them rotating in and out. And it's just like, that's not doing service to the client. Like, what the fuck? I'd rather slow it down, slow the production line down, and give adequate attention to each client, individual attention, and to see them through a very special lens, because every client is different, and you can't assume that just because you've been in this field for X number of years and you've been doing it this way that you've been doing it right. A person can be in the field for over 20 years and been doing this shit wrong for those entire 20 years because it's convenient for them. It's beneficial to them in the way that they do things, but that's not necessarily the most effective way to do it. So yeah, that's all I pretty much have to say. I want to hear from you guys. What do you guys think? Have you guys ever been to see a psychologist? And there's so much stigma around it too. And it's like, I see it from both perspectives. I was like, I can understand why there's so much stigma, because a lot of these people who got degrees and licenses, it's just like they slip through the cracks, and yeah, they may know what it takes to do the work to get the degree, but do they genuinely care about people? Are they thorough? Are they thorough with their approach to treating clients, to assessing, diagnosing, and treating clients? Like, or they just jump in there and be like, think they know shit? And it's so much projection too. I think that happens in therapy. It's like a therapist will go in there, a psychologist, I say therapist, but I really mean a psychologist, will go in there, and just because something is true for them, right, or they experience it a certain kind of way, then they'll project that onto the client and be like, okay, this is your experience. And it's like, no, that's your experience, Mr. Therapist. That's not necessarily my experience. But it happens so often. Too much projection, man, and not enough empirically validated data to support these assumptions and these hypotheses that psychologists be coming up with. Because I just be sitting in these meetings like, what? They just be guessing. Or maybe it's this. I'm like, that's too much guessing, man. I'm putting myself in the shoes of the client. Like, if I was a client and sitting in this room, I'll be like, what the fuck? Like, this is how y'all do shit? Like, this is how y'all come to a decision on how to diagnose the problem and to treat the problem? Is you just sitting around here tossing around hunches? I mean, the general public can do that. You ain't got to go to school to toss around a hunch on what's going on. I'm like, why don't we use our training to be more precise in our diagnosis and treatment of clients? That's my thing. But I can go on and on and on and on, but I'm not, because I have to go. Thank you guys for tuning in, and I will catch you guys in the next one. Share this video. Love you guys. Bye.